Discussion, I'm going to show you the 25 questions which are asked in the exam. First, I want to say 3 points here. Number 1, so I don't want to tell each and every question this is taken from the class and this is taken from the book, because all the 25 questions are easy questions in surgery and all are direct hit from Bailey and Love and direct hit from surgery 6er book. So there is no doubt any faculty will miss these questions in discussion. So there is no controversy. I don't want to discuss about it again and again, because all the questions are there in all the material and all the books. So you can go on with any standard material, you'll have this 25 question. Number 2, I have been telling regularly while discussing for exams before, I used to tell don't keep on doing multiple MCQ Q banks. There are multiple Q banks available in the market which used to threaten the students, which used to scare the students by asking tough questions. So you would have understood from this paper, this is a standard paper which every NEET PG aspirant will be understanding. Definitely it is easy paper and not a tough paper in surgery. Maybe some catch points may be there which may be making you go for some silly mistakes. Otherwise it's a standard paper which is ideal paper for a NEET PG exam. I will say this is an ideal paper for NEET PG exam. So number 3, this is the pattern you have to start preparing from now onwards. Those who are preparing for NEET PG 2022 or next to 2023, you all should start preparing like this. Don't waste your time on a lot of repeat MCQ banks, MCQs, etc. Read standard books like Bailey and Love and read all the clinical pattern questions. Understand them. They won't ask you in depth of any clinical question. They will ask you very simple superficial question from the clinical question which an undergraduate must know. So you are going to understand it from this discussion. So Mr. Ramu faced an accident and had a straddle injury. It's nothing but an injury in the groin and presents with blood at urethral meatus. What will you do next? Is exactly correct answer. Foley's catheter should not be inserted, and some people are telling there is no retrograde ureterogram in the choice, and some people are telling it is a micturating cystogram in the choice. But whatever it is, both are not the next. Please remember, even if retrograde ureterogram is there in the choice, it is not the next to be done. So when a patient comes to you with a bleeding urethra, definitely he will be having a full bladder. He will be having an urge to micturate. So next important thing you should do is to drain his urine. Even if RGU is there, many controversies and many discussions I saw in the past few days, people are telling RGU, no, RGU is not the next step. RGU will be done, retrograde ureterogram will be done, but it is not the next step. Next step is to drain the urine. Please remember, that is the answer. If you have a doubt, you can go for Bailey and Love. I'll tell you any question you have doubt, go for Bailey and Love. There will be a line clearly mentioning the points in Bailey and Love. Okay. So, safest initial management is to insert a suprapubic catheter. This is an important point I want to remember here. So, diagnosis is made by urethrography using water soluble contrast. It's not a matter now. Patient having full bladder needs to be drained by a suprapubic catheter. That's the next important step. Okay, please remember this is the answer. So this is again another question from Bailey and Love. All the questions are from Bailey and Love. I don't want to say each and every question that's come from surgery 6er or from my class, because everything which is there in Bailey and Love is covered by us in class and surgery 6er material. So male patient presents with the below image. You can see there is a gangrene involving the abdominal wall and going to the scrotum. It is not only a Fournier's gangrene. Please remember, most of them are discussing this as Fournier's gangrene. I would say this is not alone a Fournier's gangrene, it is also a Mellini's gangrene. It is a Mellini's gangrene and Fournier's gangrene are part of necrotizing fasciitis. It is a mixed aerobic and anaerobic infection which is seen. We don't do urinary diversion, we just put a Foley's catheter, that's enough. Architectomy is not needed for a Fournier's gangrene also, because we have to only excise the skin and subcutaneous tissue, and there will be shameful exposure of testis will be there. Anti-gas gangrene serum is not needed for this case. It's not a gas gangrene. In gas gangrene cases there will be crepitus will be seen, all those findings will be there, but this is not gas gangrene. It is a necrotizing fasciitis caused by aerobic and anaerobic organisms. Please remember, this condition is not caused by Clostridia. That is the first important line from Bailey and Love. So I am not discussing what is there in my surgery 6er. I want to discuss only from Bailey and Love. So testis is exposed but healthy. Mixed aerobic and anaerobic infections are there. No need of architectomy. Just go for only debridement of the wound. Okay. Every question just does not need even 1 minute discussion. That much clear question with a clear choices are there. 40-year-old male presents with frequent micturition. On examination, his urine is sterile pyuria. There is no more discussion at all. When there is a line sterile pyuria, there is no more image. I don't want the image. I don't want the choices. I will directly go for a TB kidney. A TB kidney will be having calcification, that is known as putty kidney. There will be no excuse if you are going to make mistake for this type of questions. You will have no excuse at all because it's a sterile pyuria. If you are a general MBBS final year student, you do not you do not know the picture at all. I see many times the students get scared with the images. No need to get scared with the images at all. It's a clear-cut picture of sterile pyuria, TB kidney, which is known as putty kidney. Okay. So this is directly from Balian law again. It's a cement kidney or putty kidney is a feature of chronic tuberculosis. Okay. A patient presented with vomiting and features of gastric outlet obstruction. So this is a case of GO. Please understand, patient is having vomiting. He is having tumor infiltrating from stomach to pancreas into the duodenum and having multiple liver mets in the right lobe of liver. So the treatment is very simple. There is multiple liver mets. So we are not going to do a curative resection. We are going to do only a palliation for his GOO until he is going to die. He needs to eat. He will live for 6 months for sure. We must allow him to eat. The answer is palliative gastrojejunostomy is the best answer here. No more controversy, no more discussion. It's a direct line from Balian law. Obstruction of the duodenum, surgical bypass by gastrojejunostomy is appropriate. Every word I can show you, all the 25 questions I can show you line by line from Balian law if you could give me the proper choices. A patient with no complaints presents with the dilated veins. What is the CAP classification? Clinical, etiological, anatomical, pathological classification for this image. So there is no such word known as C2B. There is no such number at all. There is no such number at all. There is only C2A, C2S. C2A is asymptomatic varicose vein. C2S is symptomatic varicose vein. That's all. Only two. C2A, C2S. So the answer here is C2A. So please remember, this is a line. C2 is varicose veins more than 3 mm diameter. S for symptomatic, A for asymptomatic. So this is asymptomatic C2A. Okay. 60-year-old male presents with increased bowel sounds. X-ray shows dilated bowel loop with air in the biliary tree. If you are a very clever student, if you are an extraordinary student prepared for surgery, you will see this is air in the biliary tree, which is known as pneumobilia. Question shows pneumobilia plus obstruction of the bowel. She gives history of open hysterectomy. Yes, history of open hysterectomy can cause adhesions. But I am not going with adhesion, which is one which can give clue for both. Pneumobilia plus obstruction plus fistula between gallbladder and duodenum is known as Rigler's triad. This is a question on Rigler's triad. They are asking a simple question on Rigler's triad. So I will go with the Gallstone ileus. Okay. This is a picture showing you. So don't worry about this image. This image is wrongly posted here. So Rigler's triad is pneumobilia, intestinal obstruction, and cholecystoenteric fistula. This is a direct line from surgery 6. So please remember this line. This is a question, not an image-based question. It's a theory question only. A patient underwent cholecystectomy and presents to hospital with a bile duct stones after 2 years. What is the name of such stones? So please understand, there is no controversy again. This is a very simple, straightforward question from Sabiston. Less than 2 years, if a patient comes to you with a stone in the bile duct, if a patient comes to you with a stone in the bile duct within 2 years, if a patient comes to you within 2 years with a stone in the bile duct, it is known as missed stone or retained stone. After 2 years, if a patient comes to us, it is known as recurrent stone. But there is no choice known as recurrent stone. So what shall I do? Recurrent stones are actually the stones which are formed in the bile duct itself. What is the name of the stone formed in bile duct itself? Because there is no gallbladder, no, so it will form now in the bile duct itself. The stones which are formed in the bile duct itself are known as primary CBD stones. So let us go with the option A. If there is an option recurrent stone, I would have gone with the recurrent stone, but there is no such option. So I am going with the primary stone. So recurrent stones are stones seen after 2 years. They are formed inside the biliary duct. They are therefore known as brown pigment stones, and they are nothing but formed in the bile duct itself are known as primary bile duct stone. Okay, please understand this question. Baby MCQ. I used to tell which are MCQs which are very simple as baby MCQs. After total thyroidectomy, doctor unable to extubate and patient shows cyanosis and respiratory distress. It is a bilateral recurrent laryngeal nerve palsy. The patient is developing stridor. Okay, no discussion at all for these type of questions. These are all questions to be discussed in basic level classes, not for a reviewed class. Okay, this is a bilateral recurrent laryngeal nerve injury known as stridor. So what surgery is shown here? This is a surgery which is obsolete. Obsolete means we are not doing any more in practice now. In fact, many books removed this surgery. Probably some of the question setter is still doing this surgery. That is why he has asked this surgery. So I think, but this anal canal, we put two opening here at 3 o'clock and 9 o'clock. Through this we will pass a wire and make it tight like this. That will prevent the rectal prolapse. It is nothing but Thiersch wiring advised for children and old age. This is known as Thiersch wiring image, which is very clear in the exam. Probably the exam question was directly taken from the question setter from his own case. So this is Thiersch wiring. Okay, Thiersch wiring is an encirclement operation for rectal prolapse. Another baby question. Metabolic finding in baby with a congenital hypertrophic pyloric stenosis. Hypochloremic, hyponatremic, metabolic alkalosis. Again, I will tell you there is no excuse. If you made a silly mistake for this question, there is no excuse. Okay, there is no excuse for that. Patient presented with a road traffic accident, complaints of breathlessness, decreased air entry into the right lung, and patient is hypotensive. What is the best? Yes, needle insertion in fifth intercostal space is best, is good, but much better answer is that wide bore needle insertion followed by resuscitation, which will be a better answer than this. I don't know these two choices. Please update the question number 11 choices if you remember in the chat box. So again, another simple baby question. Patient underwent mastectomy for carcinoma breast and presents with upper limb swallowing after 3 months. After 3 months, the patient comes to you with a lymphedema. This is upper limb lymphedema. Will they develop lymphangiosarcoma? Yes, they can definitely develop lymphangiosarcoma in future, but not so soon in 3 months. Lymphangiosarcoma will take so many months or so many years. That is known as Stewart-Trevis syndrome. Okay, so this is a picture showing you lymphedema, lymphangiosarcoma are the complications of MRM. A patient presented in emergency following blunt injury in an RTA. He had injuries in the left hypochondrium. Patient is unstable. There are multiple RTA questions, but I could not get the proper recall questions, but I will tell you all the road traffic accident questions asked in the exams are very straightforward questions. You should not have a doubt at all. Unstable, CT abdomen. No need to read anything else. Patient is stable, blunt injury abdomen. Stable patient, go for CT. Unstable patient, go for E fast. Okay, patient is unstable. What will you do next is E fast, because there is another question asking you in a stable patient. There are two questions. Unstable patient, go for E fast. If a patient is stable, go for CT abdomen. This is a direct protocol from Balian law. Again, blunt injury abdomen. Unstable patient, go for E fast. Stable patient, go for fast. So unstable patient, if fast is positive, go for laparotomy. Stable patient, fast is done first, but the definitive investigation is CT abdomen. Okay, CT abdomen is best for stable cases. Patient underwent CABG for which saphenous vein graft is taken. During the surgery, GSV is removed and the complication that can occur is saphenous nerve injury. So this is a very clear-cut question. This is a saphenous nerve is seen medially. If I remove the short saphenous vein, sural nerve can get injured. So I'll tell you guys, these are the questions discussed by me, and you will be seeing these questions will be modified, redefined and edited and will be discussed by many other surgery faculties. But what I am discussing is collected purely from my group, Surgery Sixer Facebook group and Surgery Sixer Telegram group. It's all because of you students who have given the choices and questions. I could make this discussion possible, and I dedicate this discussion session for you only. Okay, I am least bothered about the people who are going to copy these questions and going to use it, because anyhow the education gets transferred to the students and it is going to be beneficial. 35 years old male presents with abdominal distension for the past 3 days. So there is a two picture in this X-ray. One is supine X-ray is also given. This is a erect X-ray. I'll tell you, whenever you see an air under diaphragm, you should never have a doubt. You need not even read the question at all. When you see an X-ray showing air under diaphragm, go for hollow viscous perforation. And in this question, there was one more finding, that is nothing but Ryle's tube inside the stomach. If some of you ever marked gastric volvulus in this question, I'll tell you guys, you have never read gastric volvulus in your PG preparation test, because in gastric volvulus, what is the triad? We call it as Burkhardt triad. Burkhardt triad has three features, and one of the important feature is inability to pass the Ryle's tube. Inability to pass Ryle's tube into stomach is one of the feature. You go and read gastric volvulus, you will understand. So this question can never be a gastric volvulus, can never be a liver abscess, can never be a pneumothorax. So gastric volvulus will have no Ryle's tube in the stomach. Go for hollow viscous perforation. That is the correct answer. As usual, it's a simple question made to confuse you and make you wrong. Many of you would have made silly mistake in this. These are the questions which makes you go behind in the ranks. Okay. 100 times asked question, very frequently asked air under diaphragm. It's being a repeat question, no doubt at all. So this is actually an anatomy question, but I am discussing in surgery because the same concept is discussed in surgery also in Balian law. Which part of the bowel is shown here? This is valvulae conniventis. I used to tell this is a valvulae conniventis increased used. Main purpose of this is seen in jejunum to increase the absorptive surface area. Okay, this is valvulae conniventis of jejunum. This is a specimen X-ray. In operation theatre, a hernia surgery is going on. This is also an anatomy question. The sac is found medial to inferior epigastric artery. This is deep ring, this is superficial ring, this is inferior epigastric artery. If a hernia is coming lateral to the inferior epigastric artery, it is indirect hernia. If it is coming medial, it is nothing but Hasselbalch triangle. So it will be a direct hernia, and all direct hernias we do the repair, mesh repair, that is Lichtenstein mesh repair. Simple question again. So during surgery, sac is medial to inferior epigastric vessels and hernioplasty must be done. It's a clear-cut, straightforward question again. Which of the following nerve is commonly injured in submandibular gland surgery? Actually, I could not know whether they have asked common nerve injured or whether they have asked any single nerve with multiple other choices. I don't know what are the choices given in this. Please help me with the choices. Question number 18, if you know the correct choice, please post it. The nerves which are injured are, three nerves will be injured. One is marginal branch of facial nerve can be injured. Lingual nerve and hypoglossal nerve will be injured. Which nerve is commonly injured is not mentioned in books. But I will tell you, if they are asking which is the most common nerve injured, please remember the most common nerve will be a cutaneous nerve. So I will go with the marginal branch of facial nerve. But I don't think the question was asked which is the most common nerve injured is not asked. What is the nerve injured? So marginal branch of facial nerve, lingual nerve, hypoglossal nerve are the three nerves injured. Again, a repeat MCQ. A baby playing unsupervised is brought by the mother with the complaints of dysphagia for the past few hours. What is the diagnosis as per the X-ray shown here? It's an X-ray showing you a coin, no doubt. Is it in the trachea or esophagus? You cannot find out with an AP view at all. You cannot find out whether the coin is in the esophagus or in the trachea with an AP view. We have to take a lateral view. In a lateral view, you can see the air shadow of trachea, and behind this it is esophagus. Trachea is in front, esophagus is behind. So in X-ray lateral view, if the coin is in the trachea, you will see here. If it is in the esophagus, you will see posteriorly. And also they have given dysphagia, no doubt esophagus having coin. So this is again a repeat MCQ for INA common entrance and AIMS exams. 80 years old man, he may die in 5 years or 10 years due to some other cause, due to MI or some other cause he may die. He is having a prostate lesion 2 into 3 centimeter. PSA is very less, that means no meds. Gleason score is 8. 6. What is the next line of management? So very old patients who have short life expectancy, there is no need to go for a radical prostatectomy, not needed. Just wait and watch or active surveillance is enough. If the patient is having meds, I will go for orchidectomy. Orchidectomy, if at all I can do, but if it is having meds, I will go for orchidectomy. Otherwise, just wait and watch him. Most of them will not die of cancer. That is the line. Wait and watch. They will not die of cancer. They will die of something else. That is the answer for this question. So this question has been asked very frequently. Same question is asked. See, consider the no further treatment needed is answer for this patient. 85-year-old underwent TRP for prostate. Histological examination showed adenocarcinoma. No further treatment is answer. So no further treatment is answer for very old patients. So this is a very classical angio image. Angio image is showing you a male smoker presents with claudication pain in the right leg. You can see the right common iliac artery flow is there. Right side femoral artery onwards, the flow is not present. That is a formation of collateral. That is a stenosis. So it can be due to thrombus or it can be due to some stenosis. So what we should do here now? So the best thing now, recent advances, endovascular stenting. So endovascular stenting, if it is there in the choice, it is the best answer by Seldinger technique. We can put a stent inside. I can put a stent inside. Endovascular stent is the best option in recent days. The once upon a time done ioto-femoral, femoropopliteal, femorodistal, axillobifemoral, all these are obsolete. Nobody is doing this type of bypass operations. Most of the surgeries which are done by bypass are now done by stenting itself. Like a CABG is now getting low in numbers and stenting is becoming more and more common. This type of single occlusion in one place, we can easily do a stenting by a Seldinger technique. Okay, that will be the best option. But anything, the examiner is going to decide the final answer. But I will go with endovascular stenting if it is there in the choice. So this question again, I could not get the proper choices. Which of the following is wrong regarding pheochromocytoma? So VML, vinyl mandelic acid, is used in the investigation, no doubt. Alpha blocker, beta blocker, both are used preoperatively, but beta blockers should not be used first. Don't give beta blockers without starting alpha blockers. So we should start with alpha blockers first. Phenoxypenzamine daily 20 mg started. Beta blockers like propranolol to be started later. After doing an alpha blocker, then only we should give the beta blockers. We should not give it first. So this question needs full choices. I am waiting for the choices from your students. So please post 22 question choices if you get. A patient presented with abdominal distension, features suggestive of intestinal obstruction. Which part of bowel is dilated? That is again this again the anatomy question which I showed you, showing valvulae conniventis. Here the valvulae conniventis are displayed. Ileum is featureless. Colon will have harsh striations. So this is jejunum showing you valvulae conniventis. 40-year-old male presents with emergency department with acute abdominal pain and distension. Fluid-filled lesion is present in the epigastric region. So there is a fluid-filled region cyst. It is no doubt it is an acute pancreatitis with the formation of pseudocyst. Answer will be serum amylase and lipase will be elevated. Patient with a blunt injury abdomen presents with a flank ecchymosis. His vitals are stable. So I told you two questions. No, one is stable, one is unstable. Ecchymosis with a stable patient, which is the best? CT abdomen. For this patient, I will go with CT abdomen. Okay. So this patient, I will go with the CT abdomen. So these are the questions asked in NEET PG, but these are not that different question. I will tell you, these are not the 100% perfect recall. These are not the 100% straightforward questions asked in the national board exams. If you have doubts, you are always welcome. You can post the doubts in this YouTube chat box itself. I will clarify all your doubts. Thank you.